Next up, our second type of presentation format. This will be known as discussion. Panel discussions with experts on the important topics we all want to know more about. The focus here, safe long COVID rehabilitation. What we were just talking about in the discussion of our previous format. It's almost like we planned this. Session goals, what you'll walk away with. By the time this is over, you'll be able to confidently identify red flags to long COVID rehabilitation and better understand the assessments, modifications, and safe rehabilitation approaches or interventions for people living with long COVID. Let's bring in our session chair, long COVID Physio Advocacy Co-Director Canada, Jessica DeMars. Jessica.
Hi, everyone. Welcome to this discussion. I'm really excited about this one. Thanks for the introduction, Jimmy. My name is Jessica DeMars, and I am a physiotherapist working in Western Canada. And I've been working with people with long COVID since about July of 2020. As you mentioned, I'm the co-director of advocacy for long COVID physio. I'm pretty passionate about making sure my colleagues are knowledgeable about long COVID and are practicing safe rehab. So this is going to be a really great discussion. I really think that it's important that anyone who is in healthcare and is working with people with long COVID have a solid understanding of safety considerations. So as we have this discussion, I'll try to post relevant resources in Padlet to help with knowledge translation. So if there's any healthcare professionals out there today, which I know there are lots of, and you're wondering what to do, I think that this discussion today is really going to fill some of those gaps. And for those of you living with long COVID, those will be resources you can take to your healthcare professionals. I always try to do that with people that I'm seeing that have other healthcare professionals, is provide them with things that they need to take to their team. We have quite a few experts joining us today, and so I'm going to turn the floor over to them to introduce themselves, and then we'll dive into our topics today. So, Fiona.
Hello, everybody. Thank you, Jessica, for starting off our session. I'm Professor of Rehabilitation Research. I'm based in London, and I'm the co-chief investigator for the LISTEN trial, which is funded by NIHR, and it's a co-designed intervention. We're testing, it's a one-to-one self-management support intervention, and I'm a physiotherapist by background. Thank you.
Daria.
Hello, everyone. I'm Dr. Daria Oller. I'm a physical therapist and an athletic trainer at Proactivity in New Jersey in the United States. I'm one of the founding members and a co-director of education for long COVID physio, and I'm living with long COVID.
Hi, I'm Sue Pemberton. I'm an occupational therapist. I disclaim that now. And I've specialised for the past 30 years for people with myalgic encephalomyelitis, also known as chronic fatigue syndrome, and people with all sorts of post-viral fatigue conditions. And I'm in England.
Hello, I'm Doug Gross. I'm a professor in the Department of Physical Therapy at the University of Alberta in Edmonton, Canada. And I've been doing research for the last couple of years looking at people's experiences of rehabilitation with people with long COVID. Thank you.
Hello, my name is Ippokratis Angelidis. I'm pursuing a bachelor's degree in sports science. I'm also a long COVID patient of 2 years and a long COVID patient advocate. Thank you very much.
Hi, I'm Rachel Tarrant. I'm one of the clinical leads for the long COVID rehab service in Leeds in the United Kingdom. We were one of the first services to set up in the United Kingdom, and we're just reaching our 2nd year anniversary as a service. And my background is I'm a physiotherapist.
Hi, I'm Monia Verduzco-Gutierrez. Sorry, I'm in a public place at an airport right now, so I'm not going to be taking off my mask because I am still trying to be safe. And I am a physical medicine and rehabilitation physician, the chair of rehab medicine at UT Health in San Antonio. I've been taking care of patients with long COVID since the beginning of the pandemic. I'm also one of the co-investigators of the NIH Recover trial.
Hi, everybody. My name is Francis McGuire. I'm a physical therapist in Geneva, Switzerland, and I've been working with patients with autonomic disorders, long COVID and COVID for about 2 years now.
Okay, great. Thanks, everyone. We're going to have some good discussions here. So I think the first topic that we have is really relevant based on the previous presentation that we had today. There were lots of questions in the chat box, so we'll jump right into it. It is about red flags and screening. So what should we be aware of and how should we be screening for that? So we're going to turn to Monica, Daria, and Rachel for these answers or their thoughts on red flags in rehabilitation for people with long COVID. So Monica, do you want to kick us off?
Sure, happy to. So definitely, as far as, I mean, a red flag is very individualized for what it is for the person. And I just, am someone that when I start to do an evaluation from a physician perspective is hearing about the number one thing that I tell all physicians to screen for that they may not understand is post-exertional malaise. Because a lot of people may see I'm tired and yeah, I'm tired, but that is really a different thing than post-exertional malaise. So, always that's the number one thing that I look for. And to me, if there is post-exertional malaise, that is going to be a red flag and tell me that, there has to be a different kind of what we do for that patient is going to be different than someone else.
Daria, do you want to chime in?
So I will echo that with the post-exertional malaise. As a physical therapist, if we're seeing somebody in the clinic or I work on site with employer clients who are construction workers, they start reporting they're much more fatigued than usual, just getting through a typical day. And they're saying, I used to be able to do this, and now it completely wipes me out. And we're also looking at autonomic dysfunction. So if people, especially if they have wearables, which are very popular now, and they're starting to notice some weird things with their heart rate that's going much higher than usual, or even maybe a little bit lower than usual, some things with heart rate variability, HRV, and just saying, I had this data before and now this looks very different. What do you think about that? And the person might not always be tying it into their COVID infection. They might not know that they have long COVID, but starting to see those differences. And also with heat intolerance. I work with a lot of people who work outdoors, whether they're construction workers or even athletes, and they'll start to say that I don't do well in the heat anymore. Even if people living in the deep South particularly notice I used to be fine in the heat and now it's completely wiping me out. And that's for me a really big red flag.
Thanks, Daria. Yeah, that is a huge one that's happening right now is I've got so many people that just cannot tolerate the heat at all, sets everything off. Those of us in the Northern Hemisphere just went through summer and hot summer, and I think it's still continuing on in a lot of places. So it's definitely very difficult and a really worthwhile question to ask. I pretty much always ask that because people won't relate that. They'll tell you their symptoms of fatigue or breathlessness, and I usually have to ask that leading question of, do you notice a difference with temperature regulation? Are you struggling with heat or cold? Rachel, let's hear from you.
So we learned very quickly early on, as everybody else will have on this forum today, probably that's working with people with long COVID, that people weren't responding like they would normally to normal rehab approaches, and an absolutely different approach we needed to take a totally different approach and learn from this. So we use within Leeds, we use the C19YRS, which is, we use it as a screening tool. And it's been developed within Yorkshire, within our service, and it actually has all the different symptoms that people suffer with, and that does include temperature control, skin rashes, hair loss, all those other things, aside from the real main red flags like the breathlessness, the palpitations, and those sorts of things that we look at as well. So we use that as a very nice way of structuring our first assessment to be able to go through that with a patient, but also it does identify us things that we need to go back to our GPs with. So we also developed a really good guidance document for our GPs about referring into our service. So it gives them information about the different symptoms and the things they should be thinking about, the things they should be testing for, because obviously, as we are at the moment, we have no definitive biomarkers for long COVID and diagnosis for this. So it is a diagnosis of exclusion at the moment, and we do need to make sure that we're ruling out all of the pathology that could be going on alongside this. So we started that very early on, and the GPs obviously really like having a document to work with, and that seems to work really well for us. And it means that we're confident when we start rehab that it's safe, because we have ruled out all these other things. And in terms of the post-exertional symptom exacerbation, that's included within our C19, so it allows our clinicians to go through that with a patient. I think once you've started working with someone and you've seen it with your own eyes, you absolutely understand and recognise and identify these patients very quickly. And it's about learning and identifying and understanding their own personal triggers about this. So we have used the DePaul symptom questionnaire, I think that was mentioned earlier on today, but we've developed it within our own, the C19 YRS rehab scale now as well. So it's within that, we've embedded it in there, which I think is reassuring for us and patients.
Great, thank you, Rachel. And so in the Padlet discussion, I have posted a link to the YRS, the C19 YRS, as well as the DePaul symptom questionnaire for post-exertional malaise. So I think that's really important. I'm also going to post in there that there's a great resource from Physios for ME, and I know that we've got some of the Physios for ME joining us on the conference today, as well, just kind of looking at kind of some screening questions. So who should we be asking? And quite frankly, I think if anyone comes across our caseload or into our office and they have had COVID, we should be screening for essentially long COVID. So asking questions about, is there ongoing fatigue? Is there ongoing autonomic nervous system dysfunction? So are they having that temperature regulation? Are they having racing heart? Are they having unrefreshing sleep? Are they having cognitive dysfunction or brain fog, as people like to minimize it as? So I think that's really important that we are asking all patients that, because I think that those of us in healthcare know that sometimes that stuff isn't forthcoming. People don't think it's important to tell us those things because they don't think it's our role to know that. So we actually need to be asking the leading questions, I guess I would say. We're going to move on to our next question here in about a minute, but if there's anything anyone wants to add to this topic right now.
I think just also the orthostatic intolerance is a big thing to look for. And then, people will, and sometimes their heart rate may not have the typical, it goes up by 30 beats per minute, but, we don't know always what's happening to their end tidal CO2 because we don't have ways to change that. But we know that there's drops in end tidal CO2. They could be up and having dizziness and such. So it's another thing. Just look at orthostatic intolerance. And then, yes, helping people figure out how to use all their fancy devices and to be able to use that to pace themselves. I had a patient that said, I got this Fitbit and it's great. And it gives me a stress score. And I know what my score is, what I can do that day. And it limits how many steps I take. And so really able to help self-pace her with the information we have.
Great. Thank you. That's my timer there. You probably heard in the background. We are on time. This is great. So our second question or topic is, this is going to be really interesting, and I think it's going to address some of the messages in the chat box. And we're going to talk about deconditioning versus dysregulation. And so this idea, there were some questions in there about, well, how do we get people to exercise? Is this deconditioning? Am I losing muscle mass? And so this is a really, really important topic. And looking at that, do we build or do we stabilize? So Sue, I'm going to start with you.
Thank you very much. And I'm here to really bring a bit of experience from what we've learned on a very difficult journey with conditions, other post-viral conditions like ME/CFS. And historically, it was approached from that deconditioning idea that, people had symptoms such as fatigue because they were inactive due to being ill. And the idea was, well, you're weaker, you need to build stamina and tolerance. So people were on exercise programs. And we know how many people became unwell as a result of that. And actually, it was actually causing their conditions to get worse. So certainly over the last sort of decade or so, many professionals in our field have been looking at other theories and ways of understanding why these symptoms might be there. looking at the evidence around changes in the aerobic, anaerobic threshold, changes in sort of inflammatory responses, dysautonomia, and really thinking about it more as a dysregulation condition and having working theories around the idea that maybe acute illness such as COVID will impact on our everyday regulatory systems. So the autonomic nervous system, HPA axis, immune system, like we say, orthostatic tolerance. And then that causes these sort of fluctuating patterns of symptoms and post-exertional malaise or symptom exacerbation, as people have been talking about. So from my point of view as a therapist, it was really important to change our approach, that you can't just go in straight away and just say, right, build up. We just need to increase stamina and then your energy will improve. But actually, we focus very much on stabilizing first. So our approach is very much built on building orthostatic tolerance first before you start movement, heart rate, blood pressure control, making sure that people don't have low blood pressure when they're up and walking around, working on the parasympathetic nervous system, our oxygen quality, but also things like sleeping patterns, eating patterns. Have we got a routine, a balance between activity and rest? And the whole idea of stabilization is not that you reach a fixed point, but the idea that we get rid of those real sort of crashes and dips and those days where you're much worse, that we need to address that before you even start to contemplate introducing sort of extra activity or demand. So that would be kind of our basic approach to where we come to with deconditioning and dysregulation.
Great. Thank you, Sue. And I think one thing that's really important to note when we're talking about stability, and especially from a rehab professional standpoint, is that less is more, right? So we're not getting people to do things. Oftentimes we're getting people to pull back on things and do less, which is, I would say, for those that have not worked in this space before, a complete 180 of what we're used to. Francis, I'd love to hear from you.
Yeah, I completely agree with Sue. That's 100% correct. I think the differences between dysregulation and probably deconditioning is that if you get a long COVID patient to do a clinical test like 1 minute sit to stand or a 6-minute walk test, they'll often come out very normal. And I think the dysregulation, which is a really important part in rehabilitation, is that the day after they might be completely knocked out, which doesn't account for which you don't see in the test. So it's not a deconditioning in the sense that when you look at their scores, it seems relatively normal. And I think that's one of the biggest things to learn when it comes to rehab, because we like quantifying, we like doing tests, but it really has to be adapted. So if you are going to do these types of tests like 6-minute walk test or sit to stand test, first of all, you have to have really good clinical reasoning as why you're choosing those, because you might be doing more harm than good. You're probably not going to learn very much, but you should adapt it in the sense that give them a fatigue questionnaire the day after. And dysregulation is very episodic. So if we do a sit to stand for a patient who's deconditioned, their tests are going to be relatively the same from day in, day out, the next day, and then they'll get better and better. Whereas dysregulation, they might have a really good day and they'll do really well, and then they might have a bad day and they'll still do pretty good, but they'll do a lot worse. And so I think that's a key part in learning about how to treat and also understand the differences between dysregulation and deconditioning.
Great, thanks for that. Those are some really great points there, Francis. Rachel, do you have something to add?
Yeah, I think it's really important to note that within the dysregulation, and I think we see two sort of, it's not that black and white, but there are two types of patients. The hospitalised patients tend to be more of the deconditioned sort of phenotype, and the ones that weren't in hospital, that were poorly at home, tend to be the ones that are more dysregulated. Now, that's not totally black and white, there is a mix, but in our experience in Leeds, that's generally what we're seeing. And we would always screen for PESE with the hospitalised patients anyway and totally rule it out. But you can then look at the approach that you take. But I think it's really important to note we're talking about physical activity, but also a stressor. And one of the things that we really see with our patients from experience is that emotional stress and cognitive stress are big sort of triggers to deterioration in their symptoms. So actually it's identifying all three and looking at that holistically with the patient is really, really important to help them start to stabilize. So like Sue and Francis said, we often have to get patients to strip back what they're doing. So slow it down, you're doing too much. We have a period of stability, which might need months. So we might need months of stability and consistency. So we're not on this corona coaster. And then once we've had that stability, we can start to slowly look at building, but building very slowly and one thing at a time, so we know what then potentially is a trigger when things may go wrong. It isn't a trajectory it's not a smooth trajectory, this sort of recovery. It's a learning curve and it's very up and down. So, and everybody is different with that. One of the things we have found really useful, and this is kind of very new evidence that we've looked at, is that using the Borg scale with the phases of activity with people that have been identified with post-exertional malaise has been really helpful. So it's guided them to stay at a lower level activity for a period of time before they've started to build. And that's helped sort of progress people on, and it's reduced the amount of exacerbations that they've had. So we're going to look at building on that research within the team actually soon. So we'll be able to share that.
This is great. Such a good discussion, and I'm kind of keeping my eye on the chat box, and I'm also looking at our schedule today and later this morning, later in the forum, there's a workshop on pacing. So that's going to help answer some of the questions that are going through the chat box about pacing and about, well, when do we do a little bit more or things like that, and what are we monitoring for? So I think this is a really great segue into that. There were some discussions about, external stimuli and how that does. And something that's really important is that we think about meeting patients where they're at. So sometimes it may be a virtual platform because that's easier than getting a patient to come in. Maybe it's making some changes to reduce the cognitive overload. So that's something that's really important that we, especially maybe physiotherapists, physical therapists aren't thinking about, is the impact of cognitive, mental, social interactions on post-exertional malaise, post-exertional symptom exacerbation. So all things that we need to be thinking about. And again, all of these, the things that we're touching on here are also available on the Long COVID Physio website under the resources. So if people are joining us and they're like, but what do we do? Please look to that website as a resource for sure. Okay, so the next topic is interesting, and again, I really like the flow of this. We're talking about reframing expectations. So what does recovery and rehab look like in long COVID? Because I think it's really apparent that it's quite different than anything else we've seen, certainly in other chronic illness where we have perhaps some expectations already of, someone mentioned pulmonary rehab. Well, in a pulmonary rehab setting, you have an expectation based on history and I guess a lot of research into how this can be beneficial in lung diseases. And we're not necessarily dealing with that all the time with long COVID. There's going to be a subset of individuals who would benefit from pulmonary rehab, but there's going to be a large percentage of people that maybe this doesn't fit into. We might have people who are in private practice and they have someone coming in for some, something else, but there's some red flags there saying, wait a minute, they've also got fatigue in addition to their pain. So how do we reframe our expectations? So I'm going to get Fiona to chime in here on that.
Thank you. And just to give a little bit of background to my thoughts, I've been working with 30 people with long COVID. We've co-designed an intervention and approach together. So we've been doing a large qualitative piece of work. And I have to say that it's been the most incredible group to work with. And in a way, the language that I use now has come from all of them. And one of the things that really struck me about this whole idea of reframing our expectations is the double whammy, if you like, of experiencing such diverse and challenging symptoms, but then also experiencing the reactions and the assumptions and the way that people in healthcare have interacted with them. Somebody described it as you've got the sort of inner core of long COVID, and then you've got this extra outer core, which is all the other things that you have to cope with. accessing healthcare, friends and family and their reactions. And I think there's two main points that I wanted to share. One was that we've really reconceptualized the whole idea of progress and recovery, and that people wanted this point to be put across to people who are delivering our intervention, that progress is also about being able to anticipate a setback, being able to manage a setback, being able to get a period of stability, as we've talked about. So we're not thinking about recovery in a sort of stepwise linear approach, but we're really celebrating managing those setbacks as being, that's constructed as success. The second aspect is about goal setting. And goal setting is a huge area in rehabilitation. But equally, if we set a goal, we can miss or hit the goal. And when we miss a goal, actually that can make us feel worse. So, the idea of using goal setting as approach with somebody with long COVID has not been helpful from some of the experiences that I've listened to. So celebrating the bits in between, if you like, the small successes, rather than using our sort of traditional ways of goal setting, is really important. So I think I would turn it on its head and say it's not about reframing expectations of patients. It's about reframing our own assumptions, beliefs, and expectations as a healthcare community. Thank you.
Great, Fiona. That's excellent, because I think at least certainly myself as a physiotherapist, we're used to fixing or getting people to a certain level. And so again, it requires a big shift in thinking on this. Sue.
Yeah, just to really expand on that, I think in the past as well, we have had fixed expectations that people recover in a certain period of time. And there's an awful lot of patient blaming. If the patient doesn't meet those goals, it must be the patient's fault, rather than understanding that it might be the therapist's fault and that actually we're doing the wrong approach. And for patients, we're used to having a quick fix to things. So many of our patients come to clinic saying, where's the tablet? Where's the thing that's going to get me better quick? And actually understanding that change is slow. And as we were saying, it's up and down, and that life gets in the way. Your life happens alongside trying to recover from these sorts of illnesses. And because our body is impacted on by social, emotional, cognitive experiences, demands, we're going to go up and down. As we were saying, relapses happen. And not to blame the patient for that, but actually see, I reframe them as a learning opportunity. What can we learn from this? What could help us deal with this differently next time it comes round, rather than having a model of you just need to push through and it's your fault that you're not getting to that end goal, I think is really important.
Great. Thank you, Sue. Ippo, I want to turn to you now and get your perspective and your personal experience of long COVID and rehab, and, what do rehab professionals need to explore and know when working with people with long COVID?
Yes, thank you, Jessica. So my personal experience has been mixed because basically when I got sick back in 2020, I stayed sick, and I was very active before. I was an athlete, and my activity levels dropped very quickly. And then at 6 months, it got a lot worse, and I basically couldn't do anything. I was not functional at all. And then that's when I attempted pulmonary rehab, like you mentioned, with a pulmonologist. I could not tolerate it. It made me worse because I didn't really have any respiratory symptoms. My initial case was mild. But even back then, like it was mentioned before, everything was causing me to feel worse and be fatigued. I had to pace my talking, for example, which I still have to do. I can't talk for as much as I want. So of course, when I attempted exercise, I couldn't do it. When I felt a little better, I tried myself to increase movement, not exercise, because I wasn't, of course, feeling well enough to attempt any kind of exercise, even though I was exercising 5 times a week intensely, and I was a student at the Sports Science University, so I had to be very active. I attempted to increase movement, and it always, almost always, made me worse. And what I also realized was that there was a cumulative effect. Like maybe for a week, I was doing more and I was okay, but suddenly I would crash, and I was like, yeah, but I didn't do anything really demanding. But it was like that cumulative effect of the week. So yeah, 2 more anecdotes from my experience. I didn't, because I was used to exercising and I knew the basic principles of exercise, overload, or slowly increasing the stimulus and stuff like that. I could tell from the beginning, basically, that exercise was not going to work for me. Even after, almost 2 years, one day I was feeling a little better and decided I was going to try to do some pull-ups. Before I got sick, I could do maybe 15 in one set. And what surprised me was that I still could do 3 pull-ups, even though for 2 years I was 23 hours bedbound. So I was very deconditioned, but I wasn't that deconditioned that I couldn't do pull-ups. So even though I could do pull-ups, which is a demanding exercise, I can't even see my friends, for example, for more than half an hour or an hour at a time. Or I couldn't continue my studies. So what I wanted to highlight, I guess, for clinicians and researchers to explore, and what I think is worth exploring is, we know that there are some adaptations to exercise, both acute and chronic. And what I would like to see researched and assessed, I guess, is if we're able to achieve those goals, those gains in functionality, in aerobic capacity, in muscle strength, or whatever. If we do get those adaptations, will those adaptations benefit the patient, or there is something underlying there that even if you are, let's say, more muscular, you have more stamina, you still can use it? Because that is my experience, because I had, and that is my last anecdote, because I had a period of 2 months in the summer that I was feeling a little bit better, and I started doing basically moving more and doing more type of manual labor in my home and in my garden. And I noticed that my body changed, and I noticed adaptations in my musculoskeletal system. But then I crashed, and even though my body did change, and I could see changes, in my muscle mass, because I was very active before. I put on muscle mass quick again, but now I can't reap the benefit of those gains. Like, even though I was more active and there were adaptations, those adaptations are not, at least, very beneficial for me after a crash. So maybe this is something to explore. Like, if the patient is adapting, are those adaptations happening, and are they beneficial for the patient to be basically more functional, not just more, let's say, do better in an exercise test. Yes, that's about it. Thank you.
Thank you, Ippo. I think that's really important for us to consider those things that you talked about, right? Of being fit and healthy before, and this drive to get back to it, and then even getting back into some exercise and thinking that it's going to go okay, and then things crash and change again. Daria, I think you've kind of experienced that as well, haven't you?
Yes, the crashes are a really important thing to monitor for as a clinician. So I say as a patient, I previously was very physically active as a distance runner and a dancer, and I would be able to still do the things. I could still go out. I would still do a 7-mile run in the heat in the summer. And then within a few hours, literally would not be able to get up. Sometimes still, it just happened last week. I couldn't verbalize things when my husband was asking what was wrong. And you have to watch for that. And patients might not report it because they might be okay with you in the clinic in that session. And you have to ask about that. And it could range really with the crashes where we'll often say we're crashed. And sometimes we might be crashed right now and functioning, or that crash can be absolutely debilitating where the person's unable to get up. And you have to understand when someone's reporting that they're not exaggerating, that when we say we can't get up, we can't get up. You have to look at too what those crashes mean for the person. It's not only just in that moment for however long it might be. It could be hours and they could literally be weeks long. That it's not fun, but that affects our lives now because we're crashed. We can't do, not even just go to work or say like do like a fun activity, but maybe we can't shower. There was a talk going on in the chat about showering. Maybe we can't take care of our kids. We can't do really, really basic things now because we're unable to get up. So if we're as clinicians, if we're pushing someone to exercise, or somebody had asked if it was okay to exacerbate symptoms, no, because that could be absolutely detrimental to where that person's at. And what we're trying to do is stabilize our symptoms. We're trying to minimize them as much as possible. So we're able to do, again, the basic things that we need to do, let alone trying to do some bigger things. So it's so important. I cannot stress enough to ask about the crashes, not just in the moment, but how did you feel that night, the next day, maybe 2 days later? And the crashes can come from a cumulative effect, not only one session of exertion, but maybe there's a few things that were going on that ultimately led to a crash.
Great, thank you. So we've got less than 10 minutes left in our presentation, our discussion today. And what I kind of would like to do is just kind of summarize. I'd like to hear from everyone, just really briefly. It'll be about a minute or less. What take-home points, perhaps? What did Jimmy say? Like, it wasn't an elevator pitch, but what was the thing that you want people to take home about what is safe rehab? Okay. Francis, maybe I'm just going to go around the screen and ask everyone. Francis, what have you got to say about what is safe rehab?
Well, first of all, I would say red flags are really important. So make sure you're screening if you're a therapist for PTSD, desaturation, and continence. Those are often overlooked. I would say first, do no harm as a physical therapist. If they're getting exacerbation of symptoms, you're doing too much. And know when you should probably pass your job on to an occupational therapist because that might be more appropriate. And I would just leave it at that.
Great, thank you. Doug, I'm going to get you to chime in here. I know you've been quietly listening in, and you've done a lot of work in the background for this group, but what would you have to throw in on this?
Thanks, Jessica. So it's been a great discussion. I completely agree with everything that's been said, and I agree that these physical aspects of safe rehab are very important. But I guess I would highlight the importance of psychological safety. We heard this from Anne in the previous session, and we've heard many stories of people with long COVID facing stigma, disbelief from healthcare providers. So I think that it's really essential that rehab providers create a safe and supportive environment psychologically. This can be done by being authentically non-judgmental and listening with empathy, believing the patient, and building a therapeutic relationship. If this isn't the foundation, rehab is not going to be successful.
Absolutely, that's a great point. And I know there were some studies that just came out the other week that showed that patient-reported outcome measures are highly accurate in kind of diagnosing long COVID. So believe your patient. Rachel, what have you got to say?
My 3 points would be firstly screening, as we've discussed. So not just for the post-exertional symptom exacerbation, but for any other pathology that could be going on alongside these symptoms. My second point would be healthcare professionals understanding is absolutely imperative in long COVID, and having somebody as a patient, I quite often get them saying to me, oh my God, you understand, you're listening, you're validating. Just that validation and listening, and like Doug was just saying, making the patient feel safe is a really good basis and building blocks then to start working with that person and supporting them in their journey, which we know is not a short one. So that's really important. And then thirdly, personalized, individualized rehab that is symptom titrated is absolutely key to supporting these patients get better, of which I want to say positive. We have had lots of people do really, really well in our service and achieve their goals, get back to work and improve quality of life. So that's really good to know.
Great. Thank you, Rachel. Sue.
So yeah, just quick points along the same lines that, recognize post-exertional symptom exacerbation. You've got to work with that before you can do anything else. Particularly look at working at low cardiac levels when you are starting to increase people. I would certainly say you need to recognise there's lots of triggers, not just physical for symptom exacerbation. We've talked about social, cognitive, emotional, but remember things like hormones can disrupt your regulation, your diet, your sleep patterns. There's lots of things you need to consider. And finally, to reinforce what Doug said about, trust and believe your patient. It's a collaborative approach. They know what doesn't work for them. We've got to listen to them and we've got to work with them.
Great. Fiona.
Yeah, I feel as if we're like one big Venn diagram. So we all have lots of overlapping interests, but lots of shared thoughts as well. The three things I want to say, some have already been said, but I think that it should be uniquely and individualized to each person. So each person needs their own unique approach. I believe that we need to work in a much more collaborative way, which actually really focuses on people's existing and emerging expertise about living with long COVID. So we don't start from a position of knowledge and power. And then the third thing is actually how we can help people to feel more in control. And I think when people feel more in control, what they've told us is that actually they start to get to that period of stability and gain confidence in reaching that period of stability as well. So control is a very important aspect because the uncertainty and the up and downs is such a huge challenge. Thank you.
Thank you. Ippo.
Yeah, so basically, I also agree with everything that was said. I want to highlight, like you said, believing the patient. Many of us were athletes before all this. I never in my life believed that I would have someone to ask me to exercise, to recommend that I exercise, because it was, like I said, a part of my daily routine. And I think, like you said, it has to be very personalized because there's a lot of individuality and also individuality in I guess, the character of the patient. I know when I initially got sick, I was so angry and I basically tried to push through it because I was used to doing that. And I was very frustrated that I could not do what I did before. So, yeah, that's it. That's all. Thank you.
Thank you, Eppo. And Monica.
So my advice, or the thing that I love to say about rehabilitation in general is that, as a physician, there is limited access to me to see me. My visits might be, when I see the patient, I may not see them again for 3 months. And in the interim, the physio is going to be seeing them with a lot more frequency and have a much more significant relationship with them. So, to me, the physio, I can never do any of my work as a physiatrist without the PTs, OTs, speech therapists that I work with. And so I expect for them to be able to educate the patient and give them this information and be a coach for them. And also to get me the information back if there's something that you find that, I didn't have time to screen for because you took the time to do the 10-minute stand test, and you, can tell me what is going on with their heart rate so that I can start the medication, etc. So it's like, please, partner, go back to the physicians or give the information to the patient to give to the physicians. Because I know at least here we have to sign off on orders that, I get 20 a day. So I don't get to read through them all. But if a patient came to me or the physio came to me, I'd say, okay, yeah, we need to address that. And just so thank you for what you're doing.
Great. Thank you, everyone. We need to just wrap up here and just a quick summary. We need to screen for those red flags: post-exertional symptom exacerbation, post-exertional malaise, dysautonomia, orthostatic intolerance, of course, organ involvement. We need to be psychologically supportive, believe and validate what your patient is telling you. We need to have individualized care. We know this is very heterogeneous and everyone is going to present a little bit differently and everyone's going to respond a little bit differently. We need to shift our own bias. And most importantly, we need to be competent in our care, which means that you have to educate yourself. We know, speaking as a physiotherapist, there are all different realms of practice for us. I would not walk into an ICU and treat someone because I don't have enough skills in an ICU. So we need to look at long COVID that way as well. If you are not familiar with post-infectious illness, myalgic encephalomyelitis, or anything about long COVID, if you have not done the deep dive, then you should be able to recognize that I'm going to need to refer you on, or I am going to need to be upskilled. So thank you, everyone. This has been a great discussion that really is going to lead into all of the other discussions, workshops, and information we have available for healthcare professionals, people living with long COVID. So thanks, everyone, for contributing your thoughts today.